Should we go ahead and get started? Jennifer, do you want me to introduce our speakers?
Yes, you can get started. The attendance is looking pretty good.
Wonderful. So I have the great pleasure of introducing our two speakers today. So Dr. McCann, who went to medical school at the University of Virginia, residency and fellowship at Maine Medical Center, and then joined us after her fellowship training. And Dr. Braverman, who went to UF for medical school, her residency at Dartmouth. She did palliative care fellowship at Brown. She practiced in Cleveland for several years before joining us, I think almost 5 years ago now at Tampa General. And we as a residency program are really fortunate that she's been very involved with didactics for our residents too about the principles of palliative care. So look forward to hearing this talk and sharing kind of these tips with everybody at Grand Rounds.
Okay, excellent. Thank you. Are you guys seeing our slides? Just want to double check.
Looks good.
Yes.
Okay. Awesome. Thank you. So yeah, we don't always have a lot of opportunities to present, and given the breadth of our audience, we wanted to hit on a lot of different things. And so we're going to go through some tips and pearls that hopefully are relevant for you guys. And there's a lot of stuff in here, and hopefully at least something you'll catch on to and take with you. Neither of us have any financial disclosures. And here are our learning objectives. We're going to try to go through some symptom management stuff, talk a little bit about hospice, talk about family meetings, and help with some communication tips. So our first section actually is on communication. And I wanted to present about this because I have had this happen to me where I went to do a conversation with the family. I come back, I tell the primary team, you know, this is what happened, and they'll be like, what is your secret? How did you get all of that out of them? We've been talking to them every day for a week. And the secret is that there is no secret. Like as palliative providers, we have fellowship level training in communication. We've had the opportunity to do practice with feedback and have years of experience doing those. But if you take the flip side of that, the secret is that this is something that can be learned and taught. Like communication and empathy are teachable skills. These are things that you can practice and you can get better at, because nobody is born being good at this. My first tip is really a simple one. It's to listen. The reason I wanted to put this first is it's the simplest thing that you could do with the most impact. What I recommend is, you know, try when you can to focus and be present. Listen with the intent to understand and not the intention to reply. Like if you're already thinking about what your next question is, you're not really listening. The other way to check in if you're listening enough, I think for myself, I want to make sure that they talked more than I did in an encounter. My second tip is about the power of silence. So silence can be a really useful tool. The first step in using this as a tool is you have to learn to be comfortable with it, which I do have tips about. We don't have time to share them here, but if anybody wants to, I'd be happy to share separately. So you got to learn to be comfortable with it. But what I'm trying to say is, like, you're maybe having a conversation with a patient or their family. You say something difficult, then you sit in silence and you give them time to think and process what you just said, because people who are having a emotional reaction and their wheels are turning, they're not able to listen. And if you're not comfortable with silence, I've seen this happen where providers say a difficult thing and the patient doesn't talk right away, or maybe their family member, and they just start talking and filling that dead space. But that sort of dead space of quiet is actually really powerful. My third tip is probably my favorite one, and this slide is made to demonstrate that understand is a danger word and it can blow up in your face. So what I recommend is trying to avoid using it. And there's two very specific examples when you might try to avoid using the word understand. So if you're having a first interaction with a patient or their family, it's really important to figure out what they know and what they've heard. You need to know if they have all the information so that you can talk about it. But rather than asking, what do you understand? Because if you say that, probably 19 times out of 10, you can get away with it. But there's going to be that one time where you get the crossed eyes, the deep sigh, the eye roll, and they say, I understand, I'm not stupid. And that just like brings everything to a halt, because you need to know, like, did they hear about the results of the most recent imaging so that you can talk about it? So one tool that I use is you turn it around, and it's not what they understand, but ask them, what have the doctor shared with you about your condition or your loved one's condition? Because that way people might be more willing to admit that they don't have all the information that they need. They might say, you know, they told us about the most recent culture results, but we haven't heard about the CT from last night or something. So that can be really helpful. The other time that this comes up, although hopefully less commonly, I understand what you're going through. So the intent with a statement like that is an acknowledgement of the emotional impact and how difficult what this person is going through is. But you might get that same, you know, crossed arms, eyes roll, deep sigh. Do you have stage 4 cancer? And so it didn't do what you intended to do. So I couldn't possibly imagine what you're going through is maybe a way to express the same thing without stepping on that potential landmine of using the word understand. So my next tip is to avoid jargon. I include this for a reason, because I think it's something that you all have probably heard before. Like, they teach us this very early in medical training, avoid jargon. Well, yes, but it's really easy to identify jargon if it's a 6-syllable Greek word. Like, you wouldn't expect your patients to know the word hydropneumothorax. But jargon can be harder to identify when these are words that maybe are like sort of normal English words that we as a medical community use in a different manner. And so I'll give you an example that's really specific to palliative practice, but you might have come across. So be comfortable and do everything to the average man on the street are not opposites. But in the medical community, those are usually opposites. People say, you know, I just want my loved one to be comfortable. They're talking about CMO. Or if they say, I want you to do everything for, you know, my spouse, that's a very different thing. But I've had this experience in both directions where I thought that we were on one aisle, and then at the very end of the encounter, they say like, oh, and also make sure that they're comfortable. And it definitely caused my wheels to turn a little bit and be like, wait, what? So my recommendation, if you're ever in that situation, ask the follow-up question. What does comfortable mean to you? What does everything mean to you? And this can be helpful because sometimes it's, you know, that their loved one who's in the ICU on life support machines also has chronic back pain, and they want to make sure that they're not like suffering in the bed or something like that. And then my next tip is about goals of care. So as a palliative provider, I talk about goals of care probably literally every day of my medical practice, but I don't actually use those words with patients or families because they're jargon. Like, people don't know what that means. And so I think it's helpful to not specifically ask, like, what are your goals? But talk about values. That's something people find it easier to understand, because establishing goals of care is about establishing their values. Talking about outcomes rather than individual choices can be helpful. Talking about minimally acceptable quality of life and acceptable trade-offs, like what would be a meaningful quality of life to them, what's acceptable in terms of what they're willing to go through for a chance to get better. Those can really help you narrow that down. And once you've figured out what would be meaningful or acceptable, then sometimes you can go so far as to make a recommendation about this is what plan fits what you're telling me is important to you. So those are my top 5 communication tips, and I'm going to hand it over to Dr. McCann.
Now we're going to focus pretty specifically on cancer pain, because that is the type of pain that as palliative care providers we receive the bulk of our training in, and that's what our team manages here. So we're going to review a little pathophysiology of cancer pain. We're going to talk about a couple common classes of medication based on mechanism, and we're going to talk a little bit on initiation of a PCA in an opioid naive patient. So when this talk is going to pretty specifically focus on physical pain, but as a palliative care provider, really what our team is managing is what we consider total pain, or all of the different things that informs a patient's experience of pain. And there's a lot more of that than physical pain. There is spiritual pain, feeling abandoned by God because of a serious diagnosis. There's social pain, the loss of the ability to do normal activities with their friends and family. There's psychological pain, mood disorders, feeling helplessness because they're more dependent on others. And all of those experiences really inform how a patient experiences pain and what that process looks like. And so as providers in our interdisciplinary team, we try to address all of these aspects, because if we're just addressing the physical aspect, but the largest portion of their pain is spiritual pain, I'm not going to help them very much. But taking a step back and talking more about physical pain, there are two big, there's a big branch point when we start talking about physical pain. There's nociceptive pain, which is impending or actual tissue damage, versus neuropathic pain, which is impending or actual damage to nerves. Those are felt very differently by patients. And so nociceptive pain, when we're talking about somatic pain, we're talking about bony pain. I've got a new met in my femur that is painful. I can localize that. I can describe that. I can tell you about that. Versus visceral pain, when we start talking about organs, the liver capsule that's distended with mets, that pain is much harder to describe, much harder to localize. Versus neuropathic pain, which patients experience the burning, the tingling, the radiation, again, a more describable pain. And so I put the pain pathway up here not so that we can go through it, but to realize that there are multiple steps in having a painful event happen for it to go up to your brain, for you to perceive it, and then how we experience that. And so when we're making pain regimens, we are trying to take medications and target multiple areas in this pain pathway so that we can modulate the pain better for the patient, which is why so often we're recommending multiple different medications to help with management. So we're going to go over a couple classes of medications that we pretty commonly use, and you guys should feel pretty comfortable using as well. So my tips for opioids, really keep it simple. When you're starting an opioid regimen for a patient, the patients who get into trouble in the community are the ones that have complicated regimens. Really, you want one long acting, one short acting. When you start scheduling things oddly, it's hard for patients to understand that, and it leaves room for error. When you have an opioid naive patient, start at the lowest PO dose for the pill that you're choosing. When somebody's never had an opioid before, you can't predict how they're going to react to it. You can't just look at somebody and say, I think that person needs 60 milligrams of morphine. There's not a reason to say that, and it's harder to take back once you give. So it's much easier to give more if the response isn't appropriate. Please don't start long-acting opioids for uncontrolled pain. It makes it much harder to figure out what their actual morphine equivalents that they need to be comfortable are, and it puts them at an increased risk of over medicating, because you've got a long acting that's titrating on while we're doing short acting as well. It's not going to get them out of the hospital faster. And then if you're starting an opioid regimen, you got to start a bowel regimen. It's easier to stay on top than it is to catch up. So when we talk about opioids, and when I'm writing prescriptions for opioids, I'm thinking in the back of my mind, what are the pharmacokinetics of these medications? So these are probably the most common ones that we use here in the hospital. And And so when we think about onset, in the back of my mind, I know that the onset of our IV medications is much faster than the onset of our oral medications, and I'm counseling our patients on that. You know, I know you're going to feel better faster with the IV morphine. It's going to take 15 to 30 minutes for that oral morphine to work. Don't wait until you're at 10 out of 10 pain. Take it earlier so that it has time to work. Take it before you work with PT, which you know is going to be painful. The same with peak effect, really helping patients understand that so that when we start talking about taking IVs away and using PO only, they kind of understand how it's going to feel different, as well as when I'm thinking about my my PCA, when I'm bolusing that, you know, if they press a button with morphine and they're not feeling it 6 minutes later, they should be able to press it again because they should have felt the peak effect of that medication by then. And then thinking about duration. If you look at this table, there isn't a single opioid on here that has a 6-hour duration. I don't prescribe medications at 6-hour intervals because they won't last the patient 6 hours and they'll be in pain. So really thinking through what makes sense on the medication is how I'm going to prescribe it for them. PCAs, so I think if you talk to any of us, we'll say that PCAs are really great for rapid dose finding. The data supporting that is actually pretty limited, but I think it's kind of all of our experience. And I think some of the limits are there's not a lot of research in our patient population because it's such a vulnerable patient population. But there's at least one study that found that dilaudid PCA versus non-PCA titration of oral and IV medications got the patients to a comfortable state and figuring out how many morphine equivalents they needed about 2 days faster than IV and oral. But that was only in opioid tolerant patients. They did not have the same finding in opioid naive patients. Remember, not everybody is a candidate for a PCA. If the patient is too confused, too sleepy, or has short-term memory issues and isn't going to remember to use the PCA, it is not a good modality for them. If they physically can't press the button, it is not a good modality for them. We do not have a button like we do for the call lights for the PCAs. They really have to physically be able to press it. You know, thinking about the lockout interval or how much medication, how frequently they can get medication when they press the button. It's going back to the pharmacokinetics that we just went over. And then try to remember to calculate your 1 hour total limit correctly. When you're calculating that limit, you need to add in any continuous rate that you have, enough button presses that they can press the button every single time during that hour, as well as if you have a clinician bolus, that clinician bolus has to be added into the PCA total, otherwise they can't access it. So this is adapted from the University of Pittsburgh, and it's their palliative care group. It's how they suggest starting PCAs, and the top row is for opioid naive, well-ish, given our patient population, versus frail older adults. And you know, this is how I was trained, and this is my practice in opioid naive patients, and I haven't gotten into trouble with it. I think it does a pretty good job of keeping people safe and getting people comfy. So that's typically where I start if it's an opioid naive patient. I won't harp on this, but please, please, please don't prescribe tramadol. It is not a safer opioid. It is not a good alternative. We have good opioids that can be prescribed safely and work well for our cancer pain patients, so please don't use tramadol. So Tylenol, we don't really understand how it works very well. It's for mild to moderate somatic and visceral pain. Remember, it's in everything, so counsel your patients on remembering if they're using Tylenol, how much they can have and where it's coming from. It's analgesia, but it's not inflammatory. And you know, the thought for a long time was that we should put all of our patients on Tylenol because as we're escalating pains, it's one of the first things we do, and that the addition of Tylenol decreases morphine equivalents. It actually probably doesn't do that. The newer data does not support that. So the last Cochrane review in 2015 said that there is insufficient evidence to say either way. There have been several small RTCs that have come out since then that have shown that it does not reduce OME and it does not decrease pain. And so the Cochrane review has actually been pulled and they're reviewing the data again. So I think that's an area of our practice that's probably going to change in the coming years. NSAIDs, you guys know these and are pretty familiar with them. Mechanism is via COX inhibition. They're for mild to moderate visceral and somatic pain. They're great at treating inflamed states. I think the problem that we run into as palliative care providers is our patients often have contraindications to NSAIDs. So we don't get the opportunity to use them very often. And the data is really mixed with cancer pain patients, but I think it's more on the side of NSAIDs plus opioids versus opioids alone. The NSAID group actually does better from both a pain perspective as well as from a morphine equivalence perspective. So probably helpful if your patient doesn't have serious contraindications to it. Gabapentinoids, we've got two. There's gabapentin that we're probably all most familiar with. Best data in post-herpetic neuralgia and diabetic neuropathy. Remember the effect, this medication, you need to get to at least 900 milligrams a day and really much higher than that to get a good pain relief effect from it. The 100, 3 times a day, the patients are getting side effects, but they're not getting pain relief. With Lyrica, the best data is for non-cancer neuropathic pain. There's at least one study that shows that it's superior to gabapentin, amitriptyline, and placebo with an opioid-sparing effect in neuropathic cancer pain. But that study was relatively small and has not been replicated. And so when we're thinking about gabapentinoids, which one are we picking? There are a couple things to consider. So onset of Lyrica is 25 minutes versus gabapentin is 1 hour to 3 hours. Pregabalin does not have the threshold effect. So patients can get pain relief at the lowest dose. Not everybody does, but you will find patients that do. There's that one study, but in reality, Lyrica is more expensive. There are more hurdles for patients to jump through outpatient in order to get that med, and they will pay more. So I stay away from it unless they fail gabapentin. And then last, steroids, they're anti-inflammatory. I really reach for these when I'm talking about moderate to severe somatic and visceral pain. They're really great for bony pain, capsular pain, your malignant headaches from a brain tumor, malignant bowel obstruction. But as you guys all know, they have a lot of side effects, both in the short term and the long term. So you really have to balance those with the benefit you're going to get. And just from practice, dexamethasone is probably the most well-studied and the most frequently used, probably because of long half-life and low mineral corticoid activity, but there isn't a specific reason to, it's just the one that's used the most. I hand it back to Dr. Braverman.
All right, so I want to talk about family meetings because I think of this as like the procedure of palliative care. And I think we don't always think about it that way, but if you think of it as a procedure, you're more likely to have a structured approach. And if you have a structured approach, you're going to get more consistent results. So I want to take a second to think about what are the functions of this? What can it accomplish? Firstly, building rapport with families, offering support, providing medical updates, discussing prognosis, facilitating medical decision-making, and ensuring the treatment plan matches goals. Those are all things that a family meeting can accomplish. Benefits, why do we do them? I think preparing patient and family for likely outcomes, sort of setting groundwork ahead of time could be a reason. Providing the information that they need to be making good decisions, informed decisions. They also have been shown to improve satisfaction with care as well as improve psychological outcomes. So those are really good reasons. And also matching the plan of care to the goals of care, making sure that we're providing care that's meaningful to the patient, winds up generally causing us to best use our healthcare resources and not be using them for patients that don't want those things. And then indications. Who needs one? Well, a medical update might be needed because there's been a change in clinical status. Prognosis needs to be discussed. Treatment decisions need to be made, or maybe there's some disagreement either like within the family or among the family and the providers about prognosis or goals or treatments, and those things need to be resolved. So I'm going to go through my sort of mental procedure checklist. Admittedly, this is more of like a flexible framework because it's not going to work perfectly for every encounter, but I think it's helpful to have this structure in your head and bring it with you to family meetings. So my first step is to prepare for the meeting. And this is the biggest part of this. If you're having an interdisciplinary meeting and there's going to be more than one medical team, is like a pre-meeting meeting, a little huddle with the medical team so that everybody's on the same page about the agenda for the meeting and why you're doing it. If time allows, I would also say prepare for the meeting includes preparing the space. If you're going to be in a conference room, to make sure that there isn't like yesterday's lunch on the table or HIPAA information all over the whiteboard or something like that. And maybe even to put out a box of tissues on the table ahead of time. Once you get everybody in the room, introductions and agenda setting. I would say always go around, ask people what their roles, well, as medical providers, we tell them what our roles are, and the family, what's their relationship to the patient. I think this has been really helpful to me because there's been times where I thought I was meeting with the wife and then 6 ladies showed up. I'm like, oh dear, I'm actually not sure who's who because I've only been talking to her on the phone. And also I think in reverse, sometimes maybe you've been talking to the family every day and they're embarrassed to ask your name because they don't remember, and they've met so many teams that they're not really sure who's on which team. So absolutely doing introductions, stating the agenda for the meeting, like, we brought you here to discuss next steps or whatever your agenda is, but also asking the family if there's something specific that they want to accomplish, because that might be a good chance they're going to ask the questions specifically that they want to get answered. The next step is to elicit a patient or family understanding. And understanding here is in italics because this is the opportunity to ask them what they understand without using that word. What have the doctors shared with you? And get their input about what they understand. Then you're going to offer information. And what I recommend very strongly is to use a headline. So you're giving like a 30,000 foot summary. You want to give information as well as meaning. So you say, the recent CT scans showed that the cancer has grown, which means that the chemo isn't working. So you're giving both the information and the meaning of it, but try to avoid the trap of starting by going through every single step of the hospitalization and giving them a day-to-day summary, because usually for your family meeting, it's not going to be important that they know the creatinine on hospital day 4, but I think it's tempting to give them all of that information because families that really need to know more specifics, they'll ask. I think you're going to be probably discussing prognosis, and it's important to not just talk about risk of death, but I think also talk about prolonged hospitalization or cognitive and functional disabilities that might be expected, while acknowledging uncertainty, because I think a lot of times when we're having these discussions, we don't know exactly where things are going to go, but we have an idea. So one tool you can use to give that prognostic information while acknowledging that uncertainty is to talk about best case, worst case, and most likely case scenarios in terms of outcomes. And then a lot of times when you're giving this information, it's going to be difficult news and maybe not what they were expecting to hear, hoping to hear, wanting to hear. So attending to the emotion in that step can be also really important. Like the easiest tool is to name the emotion, which in doing so validates it. just the whole range, scary, stressful, sad, angry, frustrated, whatever it is that you see that they seem to be experiencing, you name it and say, it seems like you're really frustrated with whatever. And another tool that you can use if they kind of reflect back to you after you've given them information, something that's maybe not realistic, is I wish, I worry statements, saying, you know, I wish that your dad could get back to the state of health that he was in before this. I worry that might not be possible. So you don't say but, and it aligns you with their expectation without giving a false sense of hope. So after you've said whatever news you were going to give them, and before you move on to discussing treatment options, this is your opportunity to clarify the goals of care, asking them about their values and priorities. What does quality of life mean to them? You know, take this opportunity to learn about the patient as a person. What were they like before this? What mattered to them? What would they say if they could see themselves now? And then once you've got a better sense of what the family thinks the patient's values are, you then talk specifically about the treatment options and make a plan. I'd recommend talking about specific and reasonable treatment options. Like presenting treatment options that aren't actually possible isn't necessarily going to be helpful. And after presenting treatment options, ask for family input about, you know, what's their perspective, trying to make sure they're focusing on what the patient would say. And then after you've heard all that, it might be an opportunity to make a recommendation and say, you know, based on everything I'm hearing about, you know, your loved one, it seems like this is the plan that makes the most sense. You know, does that make sense to you, or does that seem to fit? And then I think once you get there, you're in that sort of wrap-up stage, concluding the meeting. I recommend, you know, doing a recap and review of the next steps and what's going forward. Summarize the areas of agreement. You know, it seems like everybody has agreed to this, or everybody understands that they would or wouldn't want X, Y, Z. If there's any decisions that have been made, to, you know, review those and discuss next steps, because sometimes the next step is going to have to be another discussion or another meeting. Maybe the family needs time to talk amongst themselves about everything that you've discussed, and then they're going to get back to you. So establish a time that somebody's going to check in with them. And then debrief with the team. This is like your post-meeting meeting, and it doesn't have to take very long. Make sure, but I think it can be helpful when there's multiple teams, make sure everybody's on the same page. Like, based on what I heard, I think this is what we're doing next. Is that what you also took away from this? It's also an opportunity to provide feedback, which is really helpful when you've got people at different levels of practice in the meeting. Just quickly talking about, you know, what went well and maybe what could be done differently next time. And then also determining who's responsible if there's a specific decision or order that needs to be placed, who's going to put it in. Like, for example, if you got to a DNR, who's going to put that order in? And while you as a team are sort of talking amongst yourself outside of the room, if you had, you know, a social worker or a chaplain with you in the meeting, that might be a chance for them to separately debrief with the family and offer any support that they need at that time. So that is my procedure checklist. I'm going to hand it back.
Now we're going to go and talk about nausea, which is one of the more common symptoms that we get consulted for. So we're going to review some mechanisms for nausea and vomiting. We're going to review some neurotransmitter activity of common antiemetics, and we're going to discuss agents used for management based on the cause of nausea. So here's the emetic pathway, and I am not showing this to you so that we can go through the specifics, but to remind everybody in the room that not everything is modulated in the same way. Not everything has the same neurotransmitter, and so Zofran does not treat all types of nausea. And so when I'm thinking about the nauseous vomiting patient, I'm going back to this and saying, what do I think is actually causing their nausea, and what is that pathway, and what are the neurotransmitters involved, so that I pick an appropriate medication based on the pathophysiology. You know, and I'm happy to share slides with anybody, but here's a quick of our common neurotransmitters kind of, and our common agents. You know, when you give this agent, what neurotransmitters are you actually going to be hitting? And so this is a big reason why you see us prescribe a lot of different things. A big reason why we prescribe a lot of olanzapine, that plus the data. So, you know, taking this information and then applying it to the patient. So thinking through causes of nausea, one of the more common mnemonics is vomit. And so we'll go through that. So V is for vestibular. This is your vertigo, base of the skull, Meniere's disease. The receptors involved in that are your cholinergic, your histamine. So the class of medications that we should use should target those. This is where this scopolamine patch can actually be helpful for vomiting. Promethazine can also help here. O is for obstruction by constipation. So there are a lot of receptors involved in this. You got your cholinergic, histamine, dopamine, serotonin, but honestly, that class of drugs that help the most with this type of vomiting are targeting the constipation and focusing on relieving that obstruction so that they can feel better. This is your Senna, your Miralax, your suppositories. So remember, when we're treating constipation, you know, we do a lot of oral meds, but if they are totally obstructed down there, they've got a big stool ball, those oral meds aren't going to work. They need to be disinfected, laxatives, suppositories. So trying to think through, you know, doing a multicentric approach to their constipation to help alleviate their nausea. M is for dysmotility of the upper gut. The receptors mainly involved in this are your cholinergic, your histamine, your 5-HT3 and 4. And so the medication that helps the most with this is a prokinetic that also hits 5-HT4, which is metoclopramide. And you'll get some dopamine with that as well, which can be helpful. I is for infection or inflammation. The receptors involved in this are your cholinergic, your histamine, your 5-HT3, your NK1. And so the classes of drugs that we use to treat related to infection and inflammation, we really try to target those. So promethazine, particularly for labyrinthitis, because that's also vestibular, and prochlorpromazine is another one that can be helpful here. T is for toxins, stimulating the chemoreceptor center in your brain. Here is where we would put our nausea related to our chemotherapy, which is a very common one that we see, but also from like electrolyte derangements, other medications, they kind of get lumped into this class because that's the mechanism that in the brain that stimulates vomiting for these patients. Dopamine, 5-HT3 are your big ones that are helpful here. And so when we talk about drug examples, when we're talking about chemo-induced nausea and vomiting, that's a great time to use Zofran in that class of medications. They actually have a lot of good data for that. And it's one of the 3 FDA-approved indications for Zofran, so this is a good place for that. But also using Haldol is really helpful for these patients because really getting that dopamine activity really can help a lot and can help with that breakthrough nausea. This is another place where, you know, I will use some olanzapine as well. There's a lot of new data coming out about olanzapine that it's particularly helpful for chemo-induced nausea and vomiting. And so we dose it nightly, somewhat preventative, but also trying to catch up. There's also new data coming out that support its use for just nausea and vomiting that we don't have a good sense of in cancer patients, probably because it hits so many receptors. And those are probably the biggest causes of vomiting that we run into. I'm going to hand it back to Dr. Braverman.
Okay, excellent. Next up on our rotating potpourri of palliative is hospice. I think the most common question that I get asked about hospice is how to talk, like how to bring it up. And my recommendation is to describe what hospice looks like without using the word hospice, because I think so many people have a preconceived notion of what that is, and they maybe don't fully appreciate the scope of that service. So an example, you know, after you've had the conversation, you've established their goals. If this is the right person and their goals are consistent with it, it sounds like what you're hoping for is to avoid coming back to the hospital, to have your symptoms controlled at home if possible, to spend the most time you can with the people you love, and to enjoy, you know, whatever it is that you've established they enjoy. Sitting on your back porch watching the sunset or whatever it is. Have I got that right? And I think often the reaction you're going to get is, yeah, doc, you really get me, or something along those lines. And if you've got it wrong, they'll tell you. But if you get that, yeah, doc, well, what you're describing is consistent with hospice, then I think you're probably going to get one of two reactions. The first is probably the most satisfying thing that happens. You get the sort of cartoonish, like, what? Like, I didn't know hospice could do that. And like, really? Cool. The other one is like, I thought I told you I want to go home. I don't want to go to hospice. And so there, I think it's really important to make sure that you're talking about the same thing, and the patient recognizes that hospice isn't just a place you go to die. I think a lot of people think of hospice as hospice houses, and they don't necessarily know about the home service piece. And hospice is a word that, you know, has multiple definitions, so there can be some confusion. You gotta make sure that you're talking about the same thing. And then, who qualifies for hospice? Who should you be having this conversation with? There's really only two factors, and it's about goals and it's about prognosis. So patients who desire a comfort-focused care, not curative care, and folks that have a prognosis of 6 months or less if the illness runs its normal course. Quick side note, if we've got any folks on this call who practice at the VA sometimes or with MedPeds and are taking care of pediatric patients, who qualifies in those settings is different. So this is for most adult patients, but not veterans. So whose job is it to determine prognosis? Or let's talk about that for a second. So estimating prognosis, there's actually a really large body of literature that we're not particularly good at this. There was a recent review article that looked at 73 different studies of prognostication. And interestingly, the direction of error varies, and there's a lot of different things that affected the direction of it. I think specialty, like what your specialty is, varies the direction of prognostic inaccuracy, whether you're shorter or longer. And also the setting that the patient is in, like an acute setting, an ER or an ICU, tended to have shorter estimates than their actual prognosis. And in like palliative settings, hospice care, advanced cancer, we tend to overestimate. One thing that can be helpful is the surprise question. This is, would I be surprised if my patient died in the next year? The reason this can be helpful is that it makes you think about the possibility rather than the probability. It's not perfect though. There was a recent meta-analysis that looked at its performance characteristics, and it's not perfect. So it's really best as a screening for, you know, which patients might benefit from hospice and palliative care. So I realized that I forgot to answer the question of who's responsible for determining prognosis. So it's the attending physician of the patient as well as the hospice doctors. So by making the referral, you're sort of putting them in this category, and then it's going to be the hospice docs who come behind you and say, yes, I certify that this is the case. So how does hospice estimate prognosis? So they use a thing called eligibility criteria. There are non-disease specific criteria. There's a handful of them, but some examples are progression of disease, worsening performance status so that they're now dependent on 2 or more ADLs, and increased healthcare utilization. So maybe they're coming to the ER quite frequently, or they're having multiple admissions. And then there's disease-specific criteria. There's 9 major categories, which I've got shown there. Not something that we have time to go through in this setting, but I would encourage you, for whatever your specialty is, to become familiar with the criteria that are specific to your practice. I have a QR code here if anybody wants to check it out. The one on the left is a pocket card. If you print it out duplex, it's a trifold little thing you could stick in your pocket. It's not meant to be an endorsement of this particular website, just a shout out to their graphic designer, because there's a lot of these references on the internet, but this was the one that I found that was like printed out most neatly. And then if anyone is feeling sort of bored or unusually motivated and wants to go directly to the source, the QR code on the right will take you to cms.gov and specifically the hospice eligibility criteria. So then now let's take a minute to talk about what hospice includes. So hospice is an interdisciplinary team. It's the doctors, whether it's the hospice doctor or the patient's own doctor, they can stay involved, nurses, aides, and homemakers. Also therapy services, PT, OT, speech therapy, if there's symptoms that are needed or services needed to control disease or enable the person to maintain ADLs and basic functional skills, they can receive therapy when they're on hospice. Counseling is a part of what's included. That's social work, chaplain, spiritual counseling, dietary counseling, as well as grief counseling for the family for a year after the time of death. Medical supplies and equipment. I think the things that I think we see commonly, hospital bed, maybe a wheelchair or a bedside commode, maybe oxygen or bandages or catheters that they need to provide that care at home. Hospice will include that. Medications is whatever prescription drugs are related to their admitting diagnosis for symptom control. Those will be included and covered by the hospice benefits. Also, short-term inpatient care is part of it. And then there's a sort of statement in the Medicare guidelines, any other service needed to manage terminal illness and related conditions. So it's really a broad benefit that patients get more out of the earlier they get referred. And that last one, the short-term inpatient care, I'm going to take a second on the next slide to talk about different levels of care of hospice, because when we talk about hospice, generally we're talking about home hospice. That's that first level of care, routine. The majority of patients on hospice are on hospice at home, wherever their home is, whether it's, you know, in a house, an apartment, if they live in a long-term care setting and that's their home, that's where they would receive it. It's a visiting service, and it's not 24/7, but they will have access. Every hospice I've worked with has like hospice hotline where they can call and get input from a nurse, and maybe the problem can be fixed over the phone. They can give them advice about try this or that, or if needed, they'll send a nurse to the house. The next one, general inpatient or GIP level of hospice care, that's hospital level hospice. This is meant to be a short-term benefit for active symptom management. So this is often what we're providing in the hospital or in the hospice house when the patients need a hospice nurse or the equivalent 24/7 to be frequently assessing their symptoms, medicating, or adjusting those medications to get their symptoms under control. The last two levels of care don't get used as frequently, but it is part of the benefit, and it's a thing that the hospices can do. Continuous care is intended to be for brief periods of crisis management in the home. The goal is to maintain the patient at home, and they can provide continuous care is a minimum of 8 hours up to 24 hours per day, at least half of which is going to be a nurse. And then respite is 5 days per benefit period. It's intended for the caregiver or care partner if they maybe needed to leave town or they've got some crisis of their own or some health issue and can't take care of this person. They can be moved to a nursing facility or a hospice house for a brief respite stay. And then I wanted to talk about hospice at TGH. How do you get them involved if you've got the patient that needs it? You have to place an order in Epic. It's called inpatient consult to hospice. There's going to be a required field for provider. I recommend everybody put LifePath Hospice there. Couple of reasons. So they are the hospice that's contracted with TGH. So they're the only hospice that can provide services inside of our building. Like when we have a CMO patient who is also engaged in hospice, that they can see the patients here. If the patient's out of county, they might not be the right hospice, but that's okay. They have liaisons on campus every day, and they receive those referrals. Like they get a notification in Epic, and they'll usually let you know if they're not the right hospice. But if you have a patient who's trying to go home and they're out of county, put the county that they want to go to in the order, and then inform the case management team, whether it's your case manager or your social worker, because they'll have to figure out who the local hospice agency is and send the referral to them. And then a note about end-of-life care here at Tampa General, because I think there's some confusion that comes up sometimes about this. So the primary team remains the primary team for comfort measures care. If the patient's in an ICU and transferring out, this is often when medicine might get consulted. Or maybe if they're on the surgery team and the surgeons don't want to do it, medicine might get consulted to take over. But I also wanted to make this distinction between hospice and palliative, because when we're doing end-of-life care, there's so much overlap that it can be confusing to know who does what. So the palliative team here at TGH, if we're consulted, we would remain as a consult team. We're not going to take over as primary, but we can assist with the active management of those patients. We can write orders and we can help with that symptom management. The hospice team, those LifePath liaisons that I mentioned who are on campus, they're nurses and a social worker sometimes. So those are folks that can't put orders in and they can't actively manage this, but they can be a huge source of support for the patients, families especially, and sometimes the nurses. So I think if they're consulted, they're not going to be writing an order, but they can be a good source of support.
Okay. With the time that we have left, we're going to try to talk a little bit about the care of the imminently dying. So we're going to discuss symptoms of the dying process as well as common management strategies at end of life. So when we think about dying, we talk about the stages of dying. Early in the process, people become more bedbound. They lose interest or ability to eat and drink, and you start to see them more tired, maybe delirious. As they continue to progress towards death, you'll see further decline in their mental status to the point where they become obtunded, and you'll start seeing urine output drop off. The late stage of death is when you start having those pooled oral secretions because they've lost their swallow reflex, coma, fevers, altered respiratory patterns, neck hyperextension, mottled extremities. And I think what is hard for patients and families is this can happen in a day. This could happen over 2 weeks. And so I think families struggle with that, and we struggle with that because we want to make sure we're providing good care, and we want to provide care in the right location. Is it okay to have this patient leave the hospital? I don't think they're going to pass away in transport. And so to that end, there are a couple ways that we start to think through who can safely get out of the hospital. Something that you'll see in all of our notes is the Palliative Performance Scale. This is a way that we grade people's functional status. It's a language that we as providers use to communicate to each other, as well as to communicate to potentially the hospice docs or the hospice team that might be receiving this patient. And the reason that we use this scale specifically is partly because there's the data behind it is for, at this performance level, this would be their expected life expectancy in an inpatient hospice unit, is where most of the data is for both cancer and non-cancer patients. It's not perfect. The data for this is older, but it's still really widely used in our field. And so trying to think through kind of newer approaches, there were two studies that came out recently that I thought were really interesting. One was investigating the process of dying, that's the top table. And the second is the East Asian Cross-Cultural Collaborative Study to Elucidate the Dying Process, or EASED. And so what these two studies did is they looked at a whole slew of physical exam findings in patients admitted to inpatient palliative care units. And what they tried to figure out is which ones of these physical exams could help me figure out if a patient's going to die in the next 3 days. And so, I took all of them out except for the ones that they thought were the most helpful. And so what's interesting here is that when we look at the likelihood ratios, like for some of these, they're really high likelihood ratios, like loss of a radial pulse. And so if that physical exam finding is present, there's a good chance that the patient's going to die in the next 3 days, according to this study. And so the ones that specifically they looked at are the loss of the radial pulse, decreased urine output, Cheyne-Stokes breathing, mandibular movement with breathing, death rattle, which is a term that we're trying to get away from, but pooled oral secretions, and then the loss of the nasolabial fold, or as sometimes our team refers to it as the O face, when everything kind of flattens and the mouth is open. While they all had good likelihood ratios, they were not specific. And so the absence of these findings, or these findings, could help you predict, yes, this patient is likely to die in the next 3 days, but if they still have them, that does not tell you the opposite is therefore true. So then they took this data and they tried to come up with predictive modeling to see if they could do a better job of figuring out who is likely to pass in the next 3 days. And honestly, they didn't do the worst job, but not the best job. I think that just goes to speak of how difficult it is to prognosticate some of these things for families. But so they took the data. The first study looked at palliative performance status, broke those patients down, then looked at dysphagia and other things to try to figure out where they were in this process. And they had some success, but 60s, not great success. And so, this is a field that is actually evolving, and there are a lot of people trying to think of a way that we can figure this out better to help with bed flow, to help with hospice, to help families and give them good information and help them start to process. So when we talk more about symptoms, pain is one of the more common symptoms that we have. I think, remember that opioids are really the treatment of choice for pain in this situation. They have been consistently shown not to shorten life expectancy here when we use them properly. Remember, there are multiple routes of administration. So if you lose an IV in one of your CMO patients, it's okay to give some sub-Q meds while we figure stuff out. We have concentrated solutions. We can give opioids rectally. There are other ways to do this than IV. And then when we talk about infusion versus bolus dosing, there's no real good data that says that infusions are better at managing symptoms in this patient population, but they are certainly easier for the nurses. And so we get, if they're in there bolusing all the time, it can sometimes be easier to start an infusion. If they're nice and comfy, but we're using a lot of PRN doses, I'll start my infusion at whatever that 24-hour OME requirement was. I'll give them a bolus of 50 to 150% of that basal rate every 10 to 20 minutes based on which opioid I'm picking in the peak analgesia effect. If their pain is uncontrolled, though, I'm going to increase that by 25 to 100% and put that into my basal rate. And then remember that rates shouldn't be adjusted frequently. The purpose of the rate is more of a baseline pain control. The patient doesn't feel the increased rate for an hour. And so if they're having an acute symptom now, increasing the rate does not help them now. You need to give them bolus medication to help now. So ordering just infusions is not an appropriate treatment technique for these patients. For dyspnea, we do a lot of non-pharmacologic things for this. One of my favorite studies was in Japan. They took hospice patients in the hospice house and they randomized them to a fan pointing to their face versus a fan pointing towards their feet. And believe it or not, fan pointing to your face lowered the dyspnea scale by 1 in 80% of patients versus pointing it at the feet where it didn't help so much. So it's just that sensation that can be really helpful. You know, oxygen therapy, in my opinion, is not the hill to die on. If families really want it, we can use it. We don't have good evidence it's helpful, especially if the patient's not hypoxic. And then opioids, and then figuring out the cause. We use Bumex in these patients all the time because if they're volume overloaded, it could help them feel better. Agitation and delirium, there's a lot less evidence for this, and it's conflicting evidence. So I think for current practice, I use neuroleptics for true agitation, swatting at nurses, getting unsafe out of bed. But the restlessness, the anxiety, I'm using my benzodiazepines. And then secretions, you know, this is an area of our practice that is currently changing. And so I think you guys will see us do different things in the coming years. So the classic teaching on this is that secretions don't bother patients. You expose them to anticholinergics, you're just treating the family. So a lot of places never treated secretions. I was in a fellowship that we did not treat secretions. But there was a really interesting study in Nature that came out relatively recently where they enrolled hospice patients and did electrophysiologic monitoring of the hearing response and found that that's intact essentially through time of death. So we know that patients, the last sense they probably lose is hearing. And then the silence study came out, and that was in Europe where they randomized patients to prophylactically dosing on scopolamine IV, which we don't have in this country, versus not treating secretions. And not only did they reduce the rate of those secretions and the quote death rattle, but caregivers and families rated the quality of death as much higher and the quality of life till time of death is higher. So I think, you know, this is an area that I think a lot of us are moving towards prophylactically treating, especially because they didn't have an increased rate in anticholinergic side effects. So that's going to change, I think, in the coming years, and I think you'll see some of changes in our team. But you know, I'm moving towards prophylactic dosing in this patient population with anticholinergics, and that's what we've got. If anybody wants slides, please feel free to reach out.
Feel free to take the mic if you have any questions.
Well, thank you everyone for your time and attention. I know we're a little bit over, so if nobody has questions, we'll let you go. But feel free to reach out to our team. We're always happy to help. You know, any questions or concerns or whatever.
Thank you both.